She didn't even get Zoom therapy or anything. She was at home with Elena and her newborn baby, who was about 3 or 4 months at the time. So um, Michelle was scrolling through the internet and she found my online toddler and preschooler course. And she joined. She didn't even tell her husband because she felt a lot of guilt because of all the denial that she went through. It wasn't that long, but as a mom that was in a state of denial for over a year when my son started showing signs of autism, I can relate to that guilt. But she took the online course, which includes a baseline language sample that we recommend. We don't ask people to turn it in. We don't look at it. We just say, before we begin, let's set a timer for 15 minutes, 30 minutes, or an hour, and listen for any sounds or words or word approximations and write it down. So Michelle, being a high school history teacher on maternity leave, was gung-ho, set a timer for a whole hour and got 2 words on baseline in that 1 hour. Started the course. The course is 60 days, but Michelle completed that course in 33 days. And then she began posting in our Facebook community. Okay, there we go. So she made amazing language gains, and she posted in the Facebook community, my child went from 2 words to 500 words in a month. And I'm like, what? I'm like, really? That sounds really amazing. And it was 500 words on a different sheet that she was using. But in the 1 hour language sample, it was 180 words and phrases. And Michelle had this on an Excel sheet. She even had the 2 words on an Excel sheet. She was very organized. And she made phenomenal gains. Her self-injurious behavior was eliminated. And at the time, I was writing my book. I wrote 2 books. My first book is The Verbal Behavior Approach, which is a 2007 book. It's in 18 languages. I've traveled around the world speaking on the verbal behavior approach early on. And then my second book, I was not going to write another book, but then I did. It's called Turn Autism Around. And I was writing this book starting in January of 2020. So when Michelle and others started posting their success, I was able to incorporate that success. And Michelle, actually, she is one of our coaches now for our program. But she was very, gave us full permission to share videos, to share pictures, to share her story. She's been on my podcast many times. But anyway, she made it into the language chapters of Turn Autism Around, chapters 8 and 9. And at the same time, so you might be going, wait, I thought this was Dr. Dennis Haircuts. Where are we going here? We'll get to that in just the next slide. But before we do, I also, because I have a PhD in leadership, I am interested in research. I do have a few peer-reviewed journal articles published. Really wanted to get this out because this actually was really more unbelievable than 2 words to 180 words. Because she had phrases too. She had contractions, she had prepositions, she had pronouns. She had all this stuff that we didn't even touch. It just basically opened the floodgates. And it was really amazing. The other really striking feature of Michelle and Elena's story was that right at the diagnosis time, when Elena was 23 months of age, she went through early intervention screening and she had Rossetti infant toddler scoring for her standardized speech testing. And one of her lowest scores on the expressive language abilities was a 0 to 3 month age of expressive language development. And as a parent, how many parents are here, first of all? Okay, about half, and then professionals, the other half? Yeah, okay. So as a parent, my son has autism. He just turned 28, and, he's 3 and he's functioning, quote unquote, 9-month age for expressive language is crushing when you get those scores, receptive ability of a 12-month-old and language, expressive language of a 9-month-old. But her Rossetti, her lowest score on the Rossetti was 0 to 3-month age at 23 months, right? Then when I interviewed Michelle, I was like, I have to talk to this woman. I don't know what happened, but that's unbelievable. And she was stuck at home. She didn't leave the house. And she didn't have any therapy. So there was really a lot of control there. So anyway, she also at 26 months of age, right after she completed the course, right a month, give or take, of that 180 words and phrases, she also had standardized language testing, and her expressive language ability. Now, it wasn't the Rossetti, because you can't do the Rossetti back to back within 3 months of each other. Her other score, I think it was the birth to 3, scored at 30 months of age for expressive language, even though she was only 26 months of age. So that was super exciting too. So I'm like, you know what? Let's get this published, because now we have COVID, we've got the shutdown, no other therapy. Mom independently taking this course. I didn't even know who she was until she posted, my child went from this to this. No feedback on videos, no anything, And now we have the language sample, which she was super organized about. Plus, it paired up really nicely with this standardized speech testing. Unfortunately, and I know this conference is big, I was on a panel yesterday with Liz in the back there, we really want evidence-based procedures and practices and programs. And it got rejected. 5 different journals rejected it because it was a case study design, but it wasn't set out to be a study. It was a retrospective study. And I think the bigger thing was, I own the program. I created the program. So I have a vested interest, even though my BCBA mentor, Dr. Rick Cabina from Penn State, helped me write up the paper. So anyway, after 5 rejections, we decided to publish it as a white paper and put a marketing spin on it. So it doesn't really look like it looked a lot more like a study when we were trying to submit it, but it is still a great study. It has all the standardized scoring in there, and you can get it at marybarbera.com/white paper. So Michelle and Elena's story her language story is in chapters 8 and 9, turnautismaround.com for the free book resources, and read more about the actual standardized scoring in the white paper. Okay, so what does this have to do with Dr. Dennis and haircuts? So after major improvements, Elena started crying during bath time, screaming during bath time. So in May of 2020, I actually looked back at our Facebook archives so I could pull out exactly what she said. She said, I'm having bath time problems with my 26-month-old daughter. So then I'm like, oh my gosh, like we helped her so much with language. Like I gotta help her. Like, what is happening? She used to love the bath time, but suddenly started crying and yelling, all done tub. That's what happens when you teach kids to communicate, right? Now she won't set foot in the tub. Even if I gently set her in the tub, she practically launches herself out immediately. I'm trying to think of what I started doing differently, but I'm at a loss. So, Elena punchline is in chapter 13 of my book, which is Desensitized Dr. Dennis and Haircut Visits. I am a registered nurse, and I am a BCBA-D and a mom. And my hypothesis right away was Elena held down during a medical procedure recently? And mom said, yes, she was. She had an MRI, an audiological testing, and she was held down. And most people would think, like, how in the world does that carry over to suddenly screaming in bath time. And that really is what happens. Things become aversive and then it spills over to other areas, including baths, including picture taking, including haircut visits. Things can come out of nowhere. But the more important thing was, how do we correct this? How do we help her correct this? And she corrected it in a week. And we're going to talk about what Michelle did with our guidance, step by step. And it's actually in chapter 13, step by step, what she did. But we're going to cover that a little bit later. But let's first now talk about aversive procedures and tasks and why young children, especially those with autism and language delays, have trouble in these areas. Got to go back on the screen so I can. Are we having trouble online?
No, you're good. I was
Okay.
going to turn on your captions.
Okay. I'm like, no, that's okay.
Okay.
So all infants are verbal. So when people say my child's nonverbal or my student's nonverbal, it's not really accurate, because we come out of the womb. Newborn babies are verbal humans. They cry to get their diapers changed. They cry to be held, to be fed. And so we are all verbal individuals, and crying is our first verbal behavior. Now, what happens is children with autism and toddlers showing signs, and even kids with language delays in expressive and receptive language abilities, they continue to cry as the main form of communication, as a response to pain and to avoid, terminate unfamiliar, scary, aversive activities. So what do we do as parents? And I know we have, professionals in the audience and watching over Zoom, and we do things like we cut their nails while they're sleeping. Anybody do that? I've done it too. And we hold down or continue tasks while the child's crying. And this can even be tasks like you're trying to teach them to tact or whatever. If a child's crying and you are working through it, you are nagging, if a child's crying, they're not learning. And crying for anything, especially at some point, you're going to have to turn off the crying by doing something. And then kids learn, I cry and things get terminated. And even though you think like, I'm in a school, I'm doing this, that has nothing to do with nail clipping or bath time, it could really affect the child across environments. So in addition to speech and expressive delays, kids with autism also have comprehension issues. They don't understand why they need to take a bath, or they don't understand why they need to have their ears checked, or they don't know if something will be painful and don't know how long it will take. So here's little Ronan. He is advanced verbally and comprehension. His mom here, Rachel Smith, is in the audience, and she shares her two boys with us all the time. And he was at a dental visit recently, and he was only 2.5. And while they're putting the chair back, he's like, why are you putting the chair back? Right? And he could ask the question, and he could also understand the answer. And how many of our kids can understand that? And so even a simple question like, why are you putting my chair back, was, an aha moment for us. Many children, including most children with autism, but even children without autism, have sensory issues. They have sensory issues to sounds, lights, touch, textures of clothing, food. Here are my boys. In the front is Lucas. He has moderate to severe autism. He was diagnosed one day before he was 3, even though my husband, who's a physician, first mentioned the possibility when Lucas was 21 months of age. In my first book, The Verbal Behavior Approach, I start out with saying my husband first mentioned the possibility at 21 months. And I told him I never, ever wanted to hear the word autism again. It's kind of ironic, because how many times do I hear it, see it, spell it, type it in a day? But Lucas, when he was young, he really didn't even start like covering his ears and having big sensory issues until he was probably 2 and 3. Spencer, my little guy behind, who's 18 months younger than Lucas, he was bothered a lot of times with tags in clothing, and he couldn't even watch me feed, mushy food to Lucas. He would start gagging. So we're on a spectrum of how sensory avoidant we are. And so it doesn't have to just deal with kids with autism, especially kids who aren't yet fully verbal. They can't ask and answer questions and understand things. They are going to be hard to manage if we don't do the right things at community outings, including Dr. Dennison haircuts. Okay, so here we are, all grown up. Spencer is 26 now. He just became a physician recently, and Lucas remains with moderate to severe autism, and he needs 24/7 supervision. Although he is very safe and independent and as happy as possible. And we've had to put a ton of supports in place to make that happen. And then my husband and I. So I really am interested in this topic. I think because of my medical background too, and then my behavior analyst background, and then of course my mom background, because I see it being a huge problem for everybody. Okay, so here are some of the activities that can and often do become aversive. We have the medical category of ear checks, shots, stitches, dental procedures, taking medicine, getting COVID tests. That was a new one to add into our mix. Self-care, toothbrushing, hand washing, bathing, hair washing, nail clipping, meal times, new foods, bedtime routines, and then community, wearing certain clothing, wearing seat belts, wearing smocks at school, tolerating noises, tolerating songs like happy birthday. Anybody know any kids that can't tolerate happy birthday? Yeah, like a lot of people. Haircuts and picture taking. So whether you're on Zoom land or here, why don't you take a pen and pencil or your phone notes and I'm going to go back to that screen, and you can write down, think of a child. If you're an educator, just think of one child and think about any of these, write down what has become aversive. And then maybe you're going to add some new things that I didn't think of here. And we'll just take a minute for you to write those down. Okay, did anybody think of any that I don't have up here that has become aversive? Can you yell it out?
Getting blood work.
Getting blood work, awesome.
Fire drills and like other drills at school.
Fire drills, if you were in Dr. Amanda and Dr. Amy's session on safety, awesome.
Diaper changes.
Diaper changes, yes.
Like clapping, like a patient or show clapping.
Yeah, clapping. Okay, noises. Go ahead.
Wearing a cast.
Wearing a cast. Yeah. And I have a client and another young child that I know that has type 1 diabetes and autism, and they have to get finger sticks and shots and an insulin pump and all kinds of things. Go ahead.
I'm gonna say like Band-Aids.
Band-Aids.
So there's
We did a Band-Aid tolerance program for Lucas when he was little, and it affected yes, no manding. I'm like, how does this happen? But we were ignoring him saying like no or whatever. And then all of a sudden, like you just have no idea it's like a whack-a-mole. It's like, are you kidding me? How did that happen? Okay, I saw another hand. Yes. toileting can be very aversive. Yeah. And I have a whole chapter on potty training in both my books, and that's huge. Yeah. I should have had that. We'll add that. Thank you.
And it's Band-Aids, but not just on him, but on us. He doesn't want, if he sees it, he's taking it off. So
Yep. It's so Band-Aids on. I'm just going to repeat it for the people in the audience. Band-Aids on you. Or like I had a client who wouldn't tolerate me where he wanted my glasses above my head, not on my face.
Yeah.
Or they don't want you to wear glasses because you usually wear contacts. Like any of these things can be aversive, right? I think there was one more hand. No? Okay. All right. So out of your list that you wrote down, let's just circle for each of you to circle 1 to 3 tasks that you think you should work on first, or because we're going to get into like, how do you work on these things? So just, and in general, we want to work on the easier things first, or the things that we're going to get more practice. So like toothbrushing before dental visits. Like I wouldn't circle dental visits because we have to brush our teeth every day, twice a day, hopefully. And nail clipping before we work on, say, ear checks, which are going to be a little harder. Okay. So within my turn autism around approach, or Barbera method, or verbal behavior approach, or whatever we're going to call it, I have 4 steps, 4 proven steps. And the reason that they're proven is it's basically the scientific method. We assess, we make a plan, we intervene or teach, and we collect data to show if something's working or not. So our step 1 of everything, whether I'm presenting on potty training or doctors or talking tantrums, we always have to start with an assessment. So if you have a plumbing problem, it's best not to just Google YouTube and try to slap it together because you may be dealing with something a lot bigger than just a little problem. And if you have a chronic cough or you feel a lump somewhere, it's best to seek professional help where they can do a full assessment, because they are trained to look for, like, it may be something bigger, it may be no problem, you may need medication, but we always have to start with an assessment. There's the Barbera method: assess, plan, teach, and evaluate using easy data. I will add that. In some ways, especially when I was working, well, not that I'm not working as a professional, but when I was in classrooms, consulting and communicating with multidisciplinary teams, I felt like in a lot of ways we were drowning in data. Who's drowning in data at the moment? No one. No one's drowning in data. Okay. So, but when we take data in, we've got to do something. We have to take smart data so that we can do stuff with it. Okay. So one of the things in my first book, in the appendices, there's a 5-page assessment that I created like 20 years ago. And on page 49 of Turn Autism Around, there's an assessment, 1-page assessment, basically that 5 pages all smushed together. And then in 2022, I decided I wanted software. So I had a software company take the 1-page assessment with a lot of help from me to score it. So in the 1-page assessment, you'll have like, does your child have sleeping problems? Does your child have safety issues? Write them all down. Now, does your child have transition issues or problem behaviors? Describe them all, which was obviously not very quantitative. Now everything in the digital assessment, which is now with a new title, it's the Barbera Early Childhood Assessment, otherwise known as the BECA. It's a 10-minute assessment. So it now, instead of saying describe sleep issues, it says, does your child or client have the following sleep issues? Doesn't sleep in their own bed, whatever. And then if they check things off online, then they either gain scores or lose scores. And you can get that assessment at marybarbera.com/assessment. But the assessment, we now have 3 buckets of scoring. It's also really great with pre and post scoring. Like we didn't have the digital assessment back when Elena was showing, delays. We had the 1-page assessment, but we're able to, even not for research purposes, even take that 1-page assessment, translate it in, and get really good pre and post scores either in real time or in the past. So it has three main categories in the assessment. And one of the categories, this category is really important as we talk about Dr. Denison haircut visits. So daily living skills and self-care tasks, eating, which picky eating is in there, utensil use, bottle use, drinking out of an open cup, drinking through a straw, pacifier use. So that's all in the eating category. Sleeping, potty training, dressing, and grooming, which are all very important skills. Also in the book and in my assessment is I incorporate, with Dr. Mark Sundberg's permission, his self-care checklist, which I think is a supplement to the VB map, and it's such a good supplement and often not done enough. So that's all in there. And then throughout the assessment, we basically rate things in terms of needs complete prompting with these skills, up to partial prompting, and then fully independent. And then we have another chunk of the assessment, which you get scores on, and that is talking and receptive abilities, as well as imitation and social skills. And then problem behaviors, whether we have major problem behaviors, sometimes major and minor problem behaviors, or just typical minor behaviors occasionally. Okay, so the action step number one is assessment. Action step number two is using that assessment to make a plan. So if your child has safety issues, for instance, and wanders and, is unaware of traffic and water and everything, that would be, as you look at the assessment that you get a printout for, or it's the one-page assessment in the book, you see, okay, safety is a big need. That need then goes on the needs part of the planning form. And we do that for every section. So we take that assessment, which looks very similar to page 49, and then we encourage parents and professionals to make a plan for the child. So it's not just, this is what we work on at school, and this is what the parents should work on, hopefully, if they know what they're doing, which is hard. These kids are tough. So here's a sample strengths and needs for a little former client named Faith. Can say 50 words. She can mand intact. She feeds herself. She sleeps through the night. She responds to her name most of the time, and she follows directions. And then her needs, even though she could say 50 words, when I start working with her at 3, even though she had a year of therapy, she couldn't yet echo or imitate, which is obviously a hugely important skill. She couldn't sing songs. She couldn't match things. And she flopped on the ground several times, 10 times a day. And potty training was a big need as well. Even though she had just turned 3, mom was paying a premium for daycare because you had to be potty trained. Otherwise, you had to pay a premium. So like all these things, like for a 3 or 2-month-old that's not echoing or imitating, I wouldn't have put potty training at the top of my list, but mom, it was at the top of her list. And we actually were able to get Faith potty trained very quickly. So with your assessment and plan, your circled priorities may change. So those things you circled may change now as the more we talk about it. So the number one thing is you always have to go with safety first. So you want to prioritize eliminating aggression, or for Faith, eliminating flopping on the ground 10 times a day, or for Elena, prioritizing scratching herself until she bled. Like those are the biggest priorities. You're going to want to prioritize crying during feeding, with or without weight loss and failure to thrive, over nail clipping, which you can continue to do while the child is sleeping for now, because, it works. If the child doesn't wake up, you can get it done. You don't have to worry about that. But obviously, If a child's crying during feeding, it poses a choking hazard. It's just not a good situation. So once you have all the big problem behaviors within these tasks prioritized, like which tasks are really the most frequent and the most safety risk, daily tasks come next. So tolerating toothbrushing before we worry about the dental visits and practicing that. And when we work on any of these skills with multiple parts, and I'm sure many of you parents and professionals in the audience know about a task analysis. And basically what a task analysis is you a list of the steps of tasks that you want to teach. So I like to limit it to 5 words per step. And there are some people that really are like, we don't ever use words during these tasks. We just prompt from behind. And I'm going to show you that I do recommend using words in the beginning to prompt the different words, but we are working on getting each step independent. Some behavior procedures we use with all of these tasks: systematic desensitization, which is just a really fancy word for pairing or repairing; reinforcement, and especially differential reinforcement. It's kind of like a jump rope, like you have to know when to go in. And sometimes you make a mistake and you're like, shoot, I went in too fast or I went in too slow. It's like a dance. So, it is good to have one person take the lead on these tasks. Like if the child's in a 2-parent household and you're working on bath time, it's probably not a good idea to be like, okay, well, I'm going to do every other night bath time, and then my husband's going to do every other night bath time, because the chances of 2 people following, the steps, and the child, some of it is like a feel of, okay, I pushed a little bit too far. And shaping and chaining and modeling and prompting and all the things that as behavior analysts we do. So I want to give a shout out to Randy Horowitz from the Eden 2 School, who I don't really know. I saw her present like 20 years ago, and she has a chapter in this very old book. And the book is called Words from Those Who Care: Further Case Studies of ABA and People with Autism. She wrote chapter 15, and it was called Who's Afraid of the Big Bad Wolf and the Dentist and the Hairdresser and the Birthday Cake and the ... And she did a really great presentation 20 years ago and gave me a lot of tips. So I do appreciate her work. I also want to give a shout out to Tag Teach. How many of you have heard of Tag Teach? Okay, just Nicole up here. Okay, so Tag Teach it stands for Teaching with Acoustical Guidance. How many have heard of like clicker training? Okay, so it basically is clicker training for humans. And I remember years ago, somewhere locally, they had an advocate and they're like, they're using clicker training for kids in the school. It's like, okay, well, first of all, I don't know what it is. So I started looking into it. It's just positive reinforcement. So I'm not an animal owner, but you think about SeaWorld, and I think about a dolphin going up and touching a marker up here for a show. Well, you're not going to be able to reinforce him actually touching the marker, but he will hear a whistle or some kind of sound to indicate that when he swims around, he earned the fish. And Tag Teach was really created by a woman named Teresa McKeon, who has been on my podcast. And I ended up to become Tag Teach certified, and Teresa came to my house, worked with me and some of my former clients years ago. And I did a presentation on Tag Teach at the ABA conference in front of BF Skinner's daughters to discuss it. I'm like, how do I get myself into these things? Like, I'm barely knowing what this is, taught my son how to tie his shoes with Tag Teach. And I'm hopefully going to show you a little video on Tag Teach to desensitize too. But basically, Teresa McKeon was a big horse lover and horse owner. And she got this wild horse that she couldn't train. And then she found out about clicker training, and she got the horse settled down, and she was very happy with that. The same time, she taught like elite athletes, little girl gymnasts, how to do gymnastics. And she was thinking about clicker training and how, when they did a cartwheel or a flip of some sort, that she could use the same procedures with a little clicker. Now, this is a clicker counter. There are actually Tag Teach clickers, which are a little louder. I like this, and I'm going to talk about this a little bit. But she would, just think of a handstand, like you okay, do a handstand, and then you get up to the position where your legs are straight, and then you come down and go like, well, your legs weren't perfectly straight. Do it again. Well, it's like, so then what she found out was, get your legs straight or blow a whistle, mark the behavior. Then you get a feel for that was great, right? And we have used, like I said, Tag Teach to teach my son shoe tying. We've also used it for a whole host of different things. And a couple of the pivotal points about Tag Teach is that's where I got my 5 words or less. And they need to be the same words. So I can't be saying these 5 words and then my husband saying these 5 words, or a teacher in power saying different words. We want to, in the beginning, have to pair the sound with a tangible reinforcement to make this a conditional reinforcement. Clickers with counters are really good for community outings, like let's go to the grocery store, good walking, or let's write your name. That's an N. That N looked great. Let's go into inclusion. Oh, now we're up to 24 points. When we get to 100, we're gonna take that trip down to deliver some mail to the hallway. It's just, it has a lot of different uses. But let me show you desensitization, if I can, with nose spraying. And this is a woman who was Tag Teach certified at a very high level. There's different levels of Tag Teach certification.
Nose spray? Come here. We gotta do nose spray, okay, sweetie? Yeah. Yeah, we gotta do nose spray, okay? Okay? Max, come here, buddy. I gotta do nose spray.
So this is just baseline.
Come here, buddy. You wanna do nose spray? Okay. Okay, Max, do you want to play the tag game with this? With the nose spray? Do you want to tag mommy? Okay, here, you tag mommy. Okay, ready? You gonna tag me? Yay, good job.
So
Okay.
that is an important step, having the child tag
tag?
you.
Oh, I have to
I
squeeze
didn't
it?
know
Okay.
that with shoe tying. She had Lucas
It jiggles. Can you
tag
tag
me doing something. It wasn't even
Can you
shoe
tag me for this
related.
one
Just
too?
put
Ready?
one finger up, and then I put 3 up, no tag. Just get the idea
It
that
jiggles.
tag meant yes, meant
Ah,
right,
thank you.
and to
You
pair it.
ready? I have to squeeze it? Okay. It jiggles. Do you want to squeeze it? Okay, you squeeze it at my nose and I'll tag you. Okay. Good job. Okay. Up the other nose. Woo! Okay. Now put it up to your nose. Okay. And I'll tag you for putting it up to your nose. Ready? Up to your nose. Good job. Yeah. Okay.
And
up
it
to your
doesn't have to
nose.
be perfect. He didn't even touch his nose.
Okay,
at
now
that
touch your
point.
nose with it.
So that's that systematic
Good
differential
job. Okay, other nose, other
reinforcement,
nostril.
shaping, pairing.
You want to do it again? Okay. Okay, now just squeeze it. Now the tag point is just squeeze it. Just squeeze. Squeeze. Good job. Okay, squeeze again. Woo! Squeeze. Woo! Squeeze. Good job. Okay, now squeeze it on your chin. Good job. Okay, squeeze on your chin again. Woo. Okay, now in your mouth. Good job. Can you do your mouth again? Can you do mommy's mouth? Ugh, salty. Okay, now put it up your nose and squeeze. Good job. Okay, up your nose. Squeeze just a little. Good job. Yeah. Okay, other nostril. Okay, squeeze just a little. Yeah. Good job. Squeeze just a little. Good job. Okay, other nostril. Okay, squeeze. Good job. Okay, can mommy squeeze? Okay. Here, and I'm just going to put it up your nose. Baxter, okay. Squeeze. Good job, you got some up there that time. Good job, yay! You gonna put the cap on? Woo!
Okay, so I think I'll let you. So I think you get the idea. And you might think, well, of course, that kid is only 2, but he's typical, obviously. He's, they're having fun, but I would say that these procedures work. You just may have to start slower. You might have to go slower. But, some of the things she did in addition to using the clicker and knowing how, to proceed is she also made it fun. She gave him a lot of control. She let him do it himself. She, encouraged spraying, in his mouth and in the air and, but think out of the box as we're thinking about pairing and reinforcement. Does anybody else, before I go on, do you have a question?
Do we know if that is like one trial that she got in the clinic?
Yeah.
Or was it multiple times that kind of sort of worked? Yeah.
It looks like that was just one big trial. It was like a 4-minute video. I know that's pretty amazing. And like, but for Lucas to teach him to tie his shoes, we did 5-minute sessions and he was 14. I was like, the only reason I did it was because I had to present at ABBA in front of B.F. Skinner's daughter. I was like, I got to do something here. I'm not just going to go up and sing and dance here. I got to present a study of some sort. So I knew that was an issue. And anyway, it took an hour total over 4 weeks of 5-minute sessions. And then it was the summertime and he wore sandals. I'm like, oh my God. And then we started out with it, and that's on YouTube too. So you can search tag teach and nose spray, tag teach and shoe tying. You'll see the whole procedure. But, I think we've had online participants who, ask big questions about their kids, like hating the doctor's office. They scream as soon as they get to the doctor's office. And when we break it down and say, let's just go to the doctor's office in the waiting room, use a clicker, have positive reinforcement, they can actually correct things pretty quickly. It's impressive. So I don't know anybody's situation here, but it is possible. And with good procedures, it's more possible. Okay. And the other big thing about tag teach, which, Teresa McKeon coming to my house, she's like a horse trainer, gymnastics coach. She's not a behavior analyst. And I'm a behavior analyst. I think I was working for the Verbal Behavior Project and years as a behavior analyst. And she comes and she's like pointing out the ridiculous mess I'm making. And I'm like, wow, really smart when you think about breaking things down. And one of the really good things that we should, as behavior analysts and teachers and professionals and even parents, 3 times with no success, we need to back up to something easier. We don't just push through. So for shoe tying, Lucas's loops were way too big. So the tag point, I think that woman was saying, tag point is spray or hold to your nose or whatever. So the tag point is make a loop. And Lucas would make this huge loop. So it's like, well, that's a loop, but it's not a good loop. We're not going to be able to work with that loop. And so after you see it's not working, my direction is not producing the skill I want, you have to back up and you have to think of a prompt. So for Lucas, we decided on putting a little piece of masking tape on this end of the loop and that end of the loop. And then the tag point was tape to tape. So if I say, I want you to lift your knee to like a 45-degree angle, but lift knee, and I'm like this, but I want lifting knee up here, but I can't get from here to there. Then you might have to move to a table, lift your knee to the table. The tag point is lift knee to table with 5 words or less, and then you get the click. So you can't just deal with a kid that's like, okay, the tag point is walk in the door of the dental office. The kid's freaking out saying no. You can't just keep going. And I think we get in trouble when we keep going and keep pushing, not realizing we got to backtrack. There's something missing here because it shouldn't be hard. Shouldn't be as hard. And then I also did a video blog, on clickers for kids with autism. And when I was in the Verbal Behavior Project and working in classrooms for a lot of my career, I saw, and we used clickers in the past to count problem behaviors. And now, since I know the importance of audible markers, I never use clickers or audible markers for problem behaviors. I only use clickers for pro-social or positive behaviors. And it's just something that I do because I know the power of it. And if a child has problem behaviors, another little side note is please don't label the problem behaviors. Johnny kicked 3 more times. Put 3 on the clicker. Who are we talking to here? And it's not going to help for any function, for any behavior. Talking about the problem behaviors or clicking problem behaviors is just not something that I recommend. The other important thing is we need a lot of practice. So we can't just work on dental visits every 6 months. We can't just work on toothbrushing if it's a problem twice a day or once a day. We can't work on bath time once every other day if bath time is a problem. We're going to have to work on it in some capacity intensively. Like if you circled one primary thing you want to work on, that's not something we can just work on here and there. We're going to have to make a plan, and we're going to have to practice in order to, that nose spray is not going to work if we just do it, if he's all squirmy and refusing, if we just do that, once a day. Desensitization sounds hard, but it's really just pairing and repairing. And I believe you can pair and repair everything. A big part of my program, the early learner materials, include potato head. So I've had parents tell me, oh, he doesn't like potato head anymore. It's like, well, he's got to like potato head. We got to repair that. If something gets unpaired, we've got to repair it if it's important to their life. So let's get back to Elena. She was held down for an MRI and an audiological assessment, which unpaired the bathtub. And I personally gave mom tips on the Facebook group because I was just like, we're not going to take this little girl who went from 2 words to 180 words in 1 hour and let her flounder and scream in the bathtub. And I knew, because of my medical background and my background pairing things extensively for kids over 2 decades, I knew I could give her some tips. However, my online course, my book, everything I do, it's not consultation. I know like 2% about this child, even though I've interviewed the mom. Like I am not there elbow to elbow, as many of you are. So what we do within our Facebook community, even if you're paying, we give you some guidelines, tell you to watch videos, give some examples, like some of the examples I said after we said, okay, you know, all right, we know she was held down. We know she's screaming. That's the baseline. So here are some possible things you could do. Could she play outside the tub? Could she be in the tub with no water with her clothes on? Could you get new tubby toys that she likes and play with no water? Does she like a little outdoor kiddie pool? Is that a possibility to repair water, or is that not a problem? Is that a problem? You know, these are some things you can try. Now you've got to choreograph the dance. You've got to decide when to jump in the jump rope, because I'm not in wherever she lives, Michigan, I think. You know, I'm not there to go back and forth. But she was able to get the bathtub repaired in 1 week. And she said a couple weeks later, "Good morning. I just wanted to share some positivity about my 27-month-old bath desensitization program. A few weeks ago, Elena loathed the tub. I had to sponge bathe her for days before I reached out to our Facebook group, but now she asks for a bath and won't even wait for me to fill the tub before climbing in. When we're all done, she says, play some more, because she doesn't want to get out. She's still pretty apprehensive about the rinsing part of the washing hair, but she tolerates it with a little bit of water at a time. Thank you for the advice and support." So then, because I'm now writing chapter 13 of my book at this point, I'm like, okay, tell me exactly what you did, please. Because I want to know. So this is on page 210 of Turn Autism Around. And this is, I mean, some of the things she picked from the list, and then she choreographed the dance. Play with favorite toys in the tub with no water in it, with clothes on, then gradually with clothes off. Gather and consider purchasing new tub toys like fishing pole with magnetic fish, bath crayons, bubble bath, cups to pour water back and forth. Those little things you play in the pool, like little spinner things where you can fill the tub with warm water and encourage the child to stand outside the tub, reach in the water to play with the toys. Encourage child to put feet in the water for a few seconds and help him or her to, in the following days, to step out safely. Because that could be a really unsafe situation. You have a child, Cody, who's also featured in my book, you know, he was aversive to bath time, and he would thrash around, and like there's a lot of hard surfaces to hit yourself. If they're trying to like jump out, depending on their size, it could be a real safety issue. Gradually, as the child stands for longer periods and plays with toys, pour water over their feet and belly and use sponge to wash. I do like to get like a separate shower handle thing that, you know, that it's not just pouring in their face, that you can control the hose. And encourage sitting in the tub may happen naturally as the child is playing with tub toys. So that was bath desensitization, which you might say, well, it's supposed to be Dr. Dennis and haircuts. But as you can see, the more I talk, the more it's like, it's all the same thing. Yes.
Got any steps for like the hair washing part in there, or was just her getting in the bathtub? Because my child can get in the bathtub, like wash, but we get to the hair.
Yeah. And she was still, when she posted at 27 months, she was still working on that. And I would say, but she was tolerating it. So some of the things that I've worked with clients with hair washing, and it is usually, you know, a big deal. But like for Cody, we had him hold a washcloth over his face. We taught him to hold his head back so that when we poured the water or used the little hose, that it wouldn't all fall in his eyes. There's even like visor things you can wear to prevent, you know, like water from splashing in their eyes. So for Cody, it was his eyes because he wore glasses too. So he'd have to get the glasses off for hair washing. And I think it was just like this whole sensory thing. So those are some of the things, but, and how old is your son?
He's 5. He just doesn't
He's-
want to test his hair, whether it's in water or.
Yeah. So he's 5, but even 5-year-olds, they can transition to taking a shower, or maybe he gets a bath every other night and then maybe he gets a shower where there's a handheld thing. And I do believe that handheld, you know, putting their head back and using a handheld hose, and you can get those pretty inexpensively at Home Depot and stuff, where you have the regular shower and then the secondary shower hose. But the important thing is have a reinforcement, make it fun, give them choices. We can count, we can sing a song as we do it. We can watch a YouTube video to prep him of other kids getting their hair washed. There's just a lot of things you can do. So hopefully that gave you some tips. Any other questions? Go ahead.
So these things take time, obviously. So I know that there's going to be a lot of parents that are going to be like, oh, my kid can't go a week or 2 without bathing, or,
Yep.
they have a doctor's appointment next week. So what do I do about that? What would be?
Yeah. So when there's not time, and we are going to talk about like emergency visits and those sorts of things, and that, a child can't go for 2 weeks without, but like Michelle sponge bathed her. She, but there are situations. I had a client in another country and she had a 17-year-old that refused showering, washing hair. Like, the key is you can't just force them because somebody's going to get hurt. And so you really have no other way to do it but to back up and to pair. And sometimes you got to work on more than 5 minutes a day. We're going to work on the standing there with no water, or find out, from your task analysis, you write down the shower or the bath or whatever. There might be a couple steps that your child or clients are okay with. And then there's a couple steps when things get wild, right? And so we may really think about how you might be able to put a prompt or a special new visor, or we're going to do something different here to, not to trick them, but to be like, hey, we found out a way to have a shower without crying. And okay, so doctor visits. And here is Ronan's older brother, Everett. Pick a child-friendly doctor, pediatrician, hopefully, with some special needs training, hopefully, whenever possible. You can watch videos on YouTube to prep, books, pictures of the setting. Work with healthcare practices to plan visits, to just, if we don't really want to visit, we just want to come in the waiting room, or, come in the waiting room. And if we could just go into the exam room to work on those initial steps, might be good. And to take pictures, practice at home with an ear otoscope and a stethoscope or a play doctor kit, using the task analysis. Like, don't think like, oh, we're just using like the kiddie stuff, so I don't really need a task analysis. We don't really have to do this. No, if we're doing practice sessions, no matter what materials we're using, we really will have the best outcome if we actually break down the steps, make it as realistic as possible. And now you can buy, back in the day, you couldn't go to CVS and get a real otoscope. You can get a real otoscope that you could actually look in their ears now, and you can pair that up if that's the problem. We also worked on like blood draws. I think somebody in the back pointed that out. Ask your doctor or where you get blood work done, like, could I take one of the tourniquets home to practice? And there's also this Buzzy bee thing that you can numb arms, and it creates like a cold numbing thing. Emla cream. It vibrates. Yeah. And there's Emla cream that can numb the area. You can use those kind of things. We use a lot of counting too with my son, like to shape things up. Like, okay, we're going to, let's sing a song and don't look, you're going to look at mommy. not that we're holding him down, but like, look at me while somebody else is helping the tech hold the arm. If you can bring a couple people to support your child, if it's like a first blood draw or you don't know how it's going to go after practice at home, you really want to bring the support so that it is successful. And you want to plan for reinforcement. I think a lot of times we think like, we're just playing with the doctor kit. We don't need to have this whole big thing. We don't need a clicker. We don't need reinforcement. We don't, when we're learning new tasks, we all need reinforcement. So we want to really look at that. And you want to plan for reinforcement, like a promise reinforcement, like, hey, we're going to do this now. And then we're going to go outside, or we're going to do this. And then we're going to go to Target, or we're going to do this. And then we're going to get a cookie. All right. So here's a sample task analysis sheet for an otoscope practice or real session, time for an ear check. I would, if I were practicing this, I know I had a child, all of a sudden he needed eye drops in his eyes. And so I show up and she's like, yeah, we have eye drops now. I'm like, great. That sounds perfect. She's like, yeah, it's not going well. And she had twins, one with autism, one without. And they were about 4 or 5. And so I go, okay, well, tell me what's happening. Like, and she goes, okay, well, I get the eye drops out and I say, okay, it's time for eye drops. And then I go, well, where does he sit or lay, or, wherever he is, like sometimes on the sofa, or sometimes I'm wrestling with him on the floor, or, it's like, okay, well, there's this first problem. Like if it's time for an ear check, a practice ear check, or a practice haircut, or we have to do real eye drops, we have to get some system where for this child that was needing the eye drops, and real eye drops, not just fake ones. We had him, I said, okay, let's have him lay on a beanbag chair that was in the family room. I go, let's have him lay on the and you can get like fake eye drops, like just saline drops to practice. So there's like another like little step. You could practice saline drops. Not that you want to do this excessively, even with his twin, like your turn. Now it's the next one's turn. But the key for him was first, like, let's find a spot. So if you're going to do ear checks, this is the practice doctor office. This is the practice chair you're going to sit in. You turn it on, the child can touch it, right ear, left ear. I mean, that makes it look like it's going to be simple, which we know it's a lot harder than that. For general visits, you can on Amazon, or used to be at the dollar store. I'm not sure if they're still there, but you could get dental kits that are actually pretty realistic with really sharp instruments. So if you are going to get dental instruments on Amazon or at the dental store, make sure that you keep the little caps on, because you don't want to be causing blood injuries, with looking in their mouth. We want to work on toothbrushing, and we could work on toothbrushing with the new choice, or a choice of different toothbrushes that sing, have musical songs, the dental kits. And then we'd want to practice with the dental kits at home, and then bring those dental instruments to the real dentist and say, well, this is what I've been doing at home. Mommy's turn, now the doctor's turn. And, some of the dental visits, I know it sounds crazy, but might just involve the dentist like brushing their teeth, counting their teeth, just to pair that up. I know that sounds expensive and a waste of time, but we got to start somewhere. And I actually have a video, I think in the next slide, show how I practice with my son. Yeah, here we go. Here we go. So this was a few years ago, and practicing on a recliner. I'm going to pretend to put this on your neck with no sound. So first, that's all right. It's only a short video. I can just look in your mouth, tell you what I'm saying. So I'm like, okay, let's open your mouth, put your hands down, and then I'm just taking the little mirror and looking in his mouth, looking up and looking down. I put on a fake little cloth.
That wasn't good. Now I'm gonna try to count his teeth. Can you feel that? Boom, boom, boom. Okay.
And I
Count
kept
your
that
teeth, okay?
cap on, let him touch it,
Open your mouth.
show that it wasn't sharp. And then I just counted his
Two,
teeth.
3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14.
And I said on the video that he used to take
You did a good
like,
job with that.
the mirror, he might bite down on it and stuff, but he, by this point he was good. So that's just a sample. I know when I saw Randy Horowitz present years ago, she actually was at a school for children with autism, and they used an outside lounge chair, like a white lounge chair, and then they'd be like, time for the dentist, and then they'd be like, we're putting your chair back, something like that. And they would do similar things, count teeth and examine the teeth. Yeah.
I'm gonna pretend to put this. I'm gonna pretend.
Okay, so haircuts. Again, we want to pick a child-friendly barber or hairdresser. We want to select a hairstyle that does not need a buzzer or scissors if those cause a problem. Like, for instance, I had a client once and I went and it was a little boy and he had gorgeous, but longer hair. And at the time I was kind of struggling with Lucas with tolerating like buzzers around the ears and stuff. And this mom has said, well, the reason he has longer hair is because he can't tolerate buzzers. And I thought, well, why are we torturing Lucas with a buzzer when he could just have a different hairstyle? But Lucas now tolerates a buzzer and everything else. We want to complete a task analysis. It's a really easy thing to practice at home. We've set up these practice haircut sessions with a lot of kids. You can use Play-Doh scissors or little kiddie scissors that don't actually cut. Or little dull scissors to start. We can use a buzzer. There's a lot of, buzzers that you might have or can get cheaply to shave beards or buzz hair. A fake cape, which is probably a problem. And something I learned, one of the things, Lucas has a reaction. He has actually an autonomic nervous system dysfunction. So he has problem behaviors related to being startled. And so that, not that he'd have problem behaviors at the haircut, but that water being sprayed, he'd be like really startled by it. And my friend who's a hairdresser pointed out that our body temperatures, when you take our temperature, it's like 98.6. That's our internal body temperature. And the water that's been sitting out is at 70 degrees. So it's like, feels like spraying cold water, which I never realized, right? So when I would go into Barbara John's salon at Kids Cut, I would right away, they knew I would take the bottle of water and go into the sink and get hot, warm water so that by the time it sprayed, it was at a nice warm temperature. But there's a little tip I didn't know. So let me tell you about Max. He was my client who made it into several chapters of my book as well. Max was never diagnosed with autism, but he had a lot of signs of autism and was almost diagnosed, and he's doing well now. But I was an early intervention professional after I left the Verbal Behavior Project. And so I was in homes with families of kids 0 to 3. And for Max, I was his only home provider for 3 hours a week. And one of our goals was he was kind of a disaster in the community. So I was allowed to go in the community with them to try to work on behavior. So I get there, mom announces, we're going for a haircut. Okay, this is not going to be pretty. I can tell right now, because I didn't know Max very well. I didn't know mom very well. She didn't know the area. This sounded like it was going to be a problem. And it was, because she had a family event or pictures or something that next week. And so she's like, we have to get his hair cut. He's a mess. So she picks like cost cutters or one of these salons, no appointment needed. No appointment was, gotten. We go in, they look at Max, who's already probably crying, look at two of us. They give the job to the the least experienced woman who looks like a deer in headlights. I'm standing back. I'm like, oh, this is not good. I don't like this. And Max is crying, thrashing. The woman is trying her best. He looks bad when he comes out. It was just a disaster. So some critical mistakes that were made, and what to do instead. Number one, mom did not select a child-friendly hair salon. We need to do that. Number two, we did not make an appointment during a quiet time with the same person. So it's not just kids cuts. For my son, it was always Barbara John. Then when he retired, it's his daughter, Michelle. All my former clients have gone to Michelle. It's just a seasoned person who's seen a lot. And then doing it during a quiet time where there's potentially not other kids crying, not other noise, not other situations going on. And we did not bring reinforcement or have a promise reinforcement. It was a new behavior. We really needed, and for any new behavior, we really need to think about reinforcement. Even if we're adding something, like for my son, he's been going to the salon, and then all of a sudden, at some point before COVID, we thought, instead of just spraying the hair, we should have him lay back and get his hair washed in the sink. So we had to think about reinforcement, see if YouTube has videos on it, which they did. They have videos on everything. Getting your hair washed in the sink at the barber shop. Okay, there's videos on that. Whether we're going to add flossing of your teeth. We have to think about reinforcement every time we start a task or we add something new and different. And we need to think about reinforcement during practice sessions and real sessions. A lot of kids with autism have noise sensitivities, and there are some parents who are like, my child can't live without headphones, or my child can't tolerate headphones, so we just give up. But headphones are one of the easiest things to pair up and desensitize, because you can plug them into, say, an iPad, so they have the visual stimulation. You can stand behind them and hold the headphones out so that the music is playing, but the child's not, having them touch, and then gradually just fade them in so that they're touching. So if a child is crying during practice or real sessions, demands are too high and/or reinforcement is too low. Your choreography is off, you've pushed too far, and now you need to stop and make a plan with easier steps, or you need to fix the steps that have become aversive. And I know behavior analysts out there are probably like, well, we can't stop in the middle of crying because that will reinforce the crying. If you've gone too far and the child is crying, you need to find a better way. So pushing through and doing escape extinction, I do not agree with. Pushing through and getting more crying. Sometimes you just have to abandon the plan. It's not the first time crying is going to be reinforced, and it won't be the last. And it's not the child's fault. And it's not even your fault. It's just there's a lot of steps and there's a lot of procedures happening and a lot of variables. And so sometimes you just have to abandon the plan and make a new plan. So sometimes practice and reinforcement aren't enough. So here's Lucas. He just turned 28. He does go under anesthesia for dental visits and other procedures, which can be done sometimes with enough pairing. So he goes under every 3 years for full cleaning, x-rays, sealants when he was younger. He had his wisdom teeth extraction done during one of these, before they got, whatever you call it, impacted. And, we did it ahead of time. And then the last time, 2 times ago, 6 years ago, right before he's going in with the dentist who's at the hospital under general anesthesia, I'm like, hey, could you check in his ears and look around? And she's like, no, I can't do that. She's like, next time, 3 years from now, you should call the ENT, make an appointment ahead of time, and we can coordinate. So when Lucas is out for anesthesia, he can do his work as well. And Lucas is someone with chronic allergies. He's had allergy shots ongoing for 14 years now. And so that was actually a really good idea. And so I made a mental note, made an appointment with the ear, nose, and throat, and he was able to look at his ears, do a full sinus check, which would have never happened with Lucas awake, and was able to give him a clean bill of health on that. So think about that. If you need blood work done, or if you need, other procedures done, and the child has to go out under anesthesia for something, it's possible. And you saw, I mean, I think if I had to, I could pair up dental visits to, but at the same time, it's like to get sealants, to get x-rays, that's a lot. So we just choose to do that. And then the question here, when there's no time to prep, emergency room visits. And little Everett here, who's 5 years old, has made 2 trips to the ER in the past 6 months, both for stitches, one in his forehead and one in his chin. He's a pretty active guy. He had a severe speech delay, but he's completely typical now. In general, if you can use a pediatric ER whenever possible, they have at our hospital, Reading Hospital, they have a specially designed pediatric ER situation with like tiles that are specially made and, sensory things and trained staff. Ideally, one parent should take the lead, and that parent needs to remain as calm as possible, because if you have both parents overreacting, and this one's saying to calm down, this one's hugging him, this one's yelling at him, whatever the situation is, one parent, to provide the support and the guidance. You want to have a to-go bag ready to go, or gather it quickly. You want to bring snacks and a drink, although don't feed or give your child anything to drink in the case of an emergency, because if they need surgery or if they need any kind of procedures, they won't want them to have eaten. So bring them, just make sure you get the clearance until you give it to them. Bring an iPad if the child likes that, special toys, a blanket, stuffed animal, change of clothes, diapers, chargers for your phone and the iPad. And stitches or other painful procedures, consider the use of nose spray or oral pain sedatives. So I know they offered Rachel, like, we could do the nose spray or we can just strap them down. I do the nose spray because we do not want to be holding kids down or strapping them down, because that really may set us back. In a dire emergency, we can definitely, use a papoose or whatever's needed. But when you can, try to keep the child safe and calm as possible, and not hold down. Offer and deliver a promise reinforcer when you're finished. So the staff was highly trained. They're like, you're going to get a popsicle when we're done. And then be the Monday morning quarterback. What went well? What could I do different? For parents out there with more severely impacted kids, not everything's going to go beautifully, but we want to pick out the things that did go well, so next time we do even better. In general, select child-friendly, special needs-friendly places. Avoid holding children down. I don't know how many times I said that. I apologize. But unless it's an emergency and there's no other way, any procedure or task can become unpaired, and we can repair it. And systematic desensitization is a key. For more information, you can always search Mary Barbera, whatever topic you're struggling with. I probably have a video, and visit my website for all my resources, marybarbera.com. Thank you.